studies together as well, and we grow together, bidnillah. So our topic today is going to be about thyroid nodules in children and adolescents. I have nothing to disclose for this topic. I'll start with a case. So our webinars named as Pediatric Endocrine Round. So imagine yourself in a round now, and or otherwise we are in clinic and we got this kind of referral. So 9-year-old girl referred for evaluation due to having thyroid swelling, otherwise goiter. She is asymptomatic. There's no symptoms suggestive of any thyroid disorder. And for the swelling that she's having at the base of her neck is not affecting her breathing or swallowing. She's not in pain. She's just having this kind of swelling. And then you, as a pediatric endocrine doctor, you are meeting with her for first time. And you took history, you examined her, and perhaps you carried on some investigations. So on your examination, it just confirmed that there is swelling actually on the right side of the thyroid. It is soft. There's no palpable nodules within the thyroid gland, and there is no palpable lymph nodes as well. But just a homogeneous swelling on the right side of the thyroid. You carried on thyroid function test, and the thyroid function test showed normal TSH and normal free T4, and thyroid peroxidase enzyme was within normal as well. So the question will be, what will be your next step? What will you do at this stage? Will you check the ultrasound or you do ultrasound neck, or you check the calcitonin, or you will arrange for fine needle aspiration or a biopsy otherwise? Or would you reassure her and discharge, reassure or follow up? So these kind of possible options. I know that you will be interested to know how big is this swelling, but yeah, let's see. Mohammed Zahid is trying to answer this question. Please, brother Mohammed Zahid, go ahead. Just unmute yourself and...
Zahid, your hand is raised. If you want to answer, unmute yourself.
What does it say?
The Muhammad Zahid said the ultrasound.
Ultrasound, okay.
He wrote in the chat box.
Okay, any other possibilities or answers? Let's have a discussion about this.
Of the affairs.
Abida as well.
So Hussein, they were writing in chat box actually. So Abda said she want to follow up and reassure.
Follow up.
Follow up, okay.
And
Hamad Haidar also would like to reassure and follow up. Okay. Last message, Muhsin, follow. Sabine would like to do ultrasound. Okay, so between ultrasound, between reassurance and follow-up. Fine, fair enough. I got the grasp from these answers. I will leave the answer till the end. We'll move on with the next slide, which is going to be my objectives for this talk. All my talk will be within these kind of boundaries. How is it normally detected, the thyroid nodule talking about? How to evaluate, what are the risk factors, and what is the guidance on the management? So the nodule can be detected by anyone, actually. We saw patients who referred by a school teacher who noticed at first and then advised the parents to get their kids evaluated. The nurses, the family physicians, general pediatricians. So parents, they could see there is a swelling on the base of the neck, and therefore they will seek advice about that. So the way of presenting, if there is obvious swelling, or sometimes if it's a big swelling and causing some pressure on the trachea, so patient will have shortness of breath or difficulty in swallowing. So those are presenting features as well, presenting symptoms. Pain can be there in some cases. Thyroid nodules can be classified either solitary thyroid nodule, a single one, or multiple. It can be cystic, fluid-filled, or solid. And further classification based on the pathology, either tumor or benign. So if we're talking about a tumor or non-tumor, so the non-tumor ones here with either a colloid cyst or a result of autoimmune thyroiditis, or a multinodular goiter, hyperplastic nodule, or thyroglossal cyst. If we're talking about tumors either benign or malignant. Benign tumor, like a toxic adenoma or non-functioning follicular adenoma, and the malignant neoplasm, whether primary or secondary due to metastasis plus lymphoma. The primary can be papillary, follicular, medullary, or anaplastic. The most common one from the primary carcinomas is the papillary thyroid cancer. Why is it important that we need to take the thyroid nodule as a serious topic? Why we need to be concerned about it? Why we need to investigate? Why we need to be educated about it? The fact is, thyroid nodule in children reported to be 2 times or 3 times increased risk of being malignant when compared to thyroid nodule in adults. In other words, if we have an adult coming with thyroid nodule, the chances for this nodule to be as a result of a malignancy or turned over to be malignancy is less than if we see a thyroid nodule in a child. I know thyroid nodule in children is uncommon, is not that common condition. Perhaps it's less than 5% of children would have thyroid nodules. So it's not that very common condition. However, the risk of that nodule to be a result of malignancy or will tend to malignancy is much higher compared to adults. And this is a first learning point that we need to understand. So if we bear this in mind, that thyroid nodule can be having increased risk of being malignancy in pediatrics, therefore we should be very careful when we assess patients coming to us with thyroid nodule. So we need to have a thorough examination, assessment, and clinical evaluation before we consider discharging this child or adolescent from our clinics. Differentiated thyroid cancer more often present with advanced disease at diagnosis in pediatrics. So if a child coming with will have thyroid cancer, usually it becomes advanced at a very quick period of time. Therefore, at time of diagnosis, perhaps we see the case is advanced compared to an adult, which takes a bit longer time to, for example, metastasize or involve lymph nodes, or to have multifocal disease compared in pediatrics. So the risk for children of a clinically relevant thyroid nodule, and when we talk about clinically relevant thyroid nodule, we take a cutoff of more than 1 centimeter. Being malignant is 20 to 25% compared to only 5 to 10% for thyroid nodule in adults, respectively. So how to evaluate thyroid nodules? The first step is ultrasound. Yes, we do thyroid function test first, but thyroid ultrasound is a very important tool of evaluation because it's painless, it's non-invasive, it's quick, no radiation, and great details of the thyroid actually, because the thyroid is very close to the skin, and the probes of these days that we used used by radiologists will give a significant details of the thyroid when it's looked at. So this is how it looks like if we have a transverse section. So this is the trachea, this is the isthmus, the right lobe, the left lobe. Usually the esophagus is on this side, and here are the blood vessels. So when we assess thyroid on ultrasound, it's important that we know this kind of anatomical structures, and we look for the similarity between the right and left lobe. We talk about the similarity in the anatomy, and we look into the ecotexture as well, whether echogenic or hypoechoic or hyperechoic, or if there's any calcification, like white dots in there or not. Of course, if there is any abnormality there, then we need to look at the description of that abnormality later on. This paper written by Jennifer Hess, she concluded in her paper that ultrasound is superior to palpation for thyroid cancer detection in high-risk childhood cancer and BMT survivors. We know those patients who had radiation, they are whatever of radiation, whether natural exposure to radiation or as part of treatment to any kind of underlying cancer, that itself could increase the risk of child having actually thyroid cancer. So it's recommended for those patients to have regular kind of surveillance and follow-up. So if a child who is a cancer survivor for any other cause, and then you do evaluation to make sure they are not developing thyroid cancer, and if we take two cohort of patients, one of them, they had their evaluation by palpation only, and the other group, they had palpation and ultrasound. Of course, what Jennifer had found, that patients with ultrasound and palpation, they had the undercurve area of 0.865, so will detect majority of cases. Whereas patients who had palpation only, they will detect less number of cases compared to the palpation and ultrasound. So the second learning lesson perhaps tonight is when we assess thyroid nodule, clinical examination is important, blood investigation is important, and ultrasound of thyroid gland is of great value and importance. So we should not omit this fact. It's very important to tell us more about the structure itself, the type of the echogenicity and vascularization as well. A question: what is the sensitivity and specificity of thyroid ultrasound for distinction of thyroid cancer from benign thyroid nodule of a child? Now, so we said it's important to be done. And now that if we have done it and we found abnormality, is the ultrasound going to differentiate and distinct the thyroid cancer from benign thyroid nodule? The level of evidence saying there is a moderate level of evidence with quality evidence that supports this. Okay, so in this paper by Jason Kwan, pediatric thyroid cancer incidence and mortality trends in United States between 1973 to 2013. It's a very longitudinal study, very important, called SEER study. They looked into 9 databases, and SEER stands for surveillance, epidemiology, and end results. And they had 1,806 patients included in the analysis. Most patients who had pediatric thyroid cancer were aged 15 to 19 years. And the incident rates of pediatric thyroid cancer increased rapidly between from 2006 onward to 2013 compared to 1973 to 2006. As you see here, this is for all patients. You could see that the incidence of thyroid cancer was about 0.48 in the 70s. And then the incidence had gone up to 1.14 per 100,000 persons in the US. And if we look at the gender, so in females, more prevalence, the prevalence is higher than in males. And if look into the ethnicities, and it's in the white people more than the others in the US, according to these 9 databases. The question is why? What happened to make the incidence going higher after 2006? Is the disease becoming more progressive? Why do you think the incidence had gone up? Let's have some answers here in the chat box. Let's have some answers. Why do you think the incidence has gone up?
So yet there is no answer.
Tahir thinks it because of cancer survivals. Yeah. What else?
Okay.
Okay, so ultrasound, of course, because people start using more ultrasound. You're right, absolutely. So basically, the answer to this is because the people start using more ultrasound follow-up in different cases. So patients with Graves' disease, as an example, the recommendation is to have a follow-up on the ultrasound thyroid. Patients with McCune-Albright syndrome, for example, there is a recommendation that you check the thyroid by imaging, as well as patients with P10 mutation, for example, because they are at higher risk of developing thyroid cancer, as well as patients with DICER1 mutation, and of course the cancer survivors. So basically, the surveillance and the use of ultrasound more frequently has helped in detecting more and more cases. Let me see the chat. People do write things here. Environmental and food. Well, more diagnostic technology. I agree, Versha. It's more of diagnostic technology perhaps than the food. I'm not 100% sure that the food is playing a role in increasing thyroid cancer. Perhaps use of I'm not sure. I'm not sure that the food is playing a role in this. But if anyone has got evidence for that, that would be great to be shared with us. Okay, so findings of thyroid ultrasound examination within 3 years after the Fukushima nuclear power plant accident. So that was kind of natural exposure to radiation. And what they found is, so they had a number of patients who participated in the screening program. 294,905 participants aged under 18 who get thyroid ultrasound examination. And those patients, you could see here, those are male subjects. They had 1,400 patients. And for female subjects, they had 2,455. The thyroid nodules were detected more towards adolescents compared to young age groups. That's in male as well as in female. And in females, the detection was even higher than in males. And that goes with actually the risk factors for developing thyroid nodules. It's more common in females than males. And it's if you look at the age group, it's more in the pubertal age group compared to pre-puberty. So that again here, the same data being plotted on this chart as well shows here that before age of 10, the incidence is equivocal and it's equal between males and females, but afterwards, the incidence is higher in females compared to males. Similarly here, that looking at the size of the thyroid nodule detected in those patients that we just referred to, it seems to be the size is getting bigger as the person advancing in age. So during the adolescence, the size of the nodule is higher and bigger than the size of the nodule in prepubertal children. Now, adjusted detection rates of thyroid nodules by age and gender on this graph, again, basically just second what we were just saying. So it's small nodules in the prepubertal age, and detection is less than in after puberty. So the detection goes higher after puberty. The question will be here, what is the prevalence of non-clinically relevant thyroid nodules in a child? And the prevalence non-clinically relevant thyroid nodule in non-childhood cancer survivor cohort of children seems to be vary between 0.6 and 2%. So it's still not that common condition. Okay, so how can we evaluate a thyroid nodule? It depends on the setting. Where are you based? that some hospitals and some healthcare facilities, they have designated thyroid nodule clinic. The best practice saying that if the patient is seen jointly by endocrinologist and thyroid radiologist at the same time. So they could have the evaluation together between radiologist and the endocrinologist. And that could help to decide on the time whether this patient needs fine needle aspiration or fine needle biopsy on spot. But unfortunately, this is not the practice worldwide. But this, if I have access to this practice, that would be a best option for the patients. So that's stopping patients to keep going and traveling between facilities or departments on waiting for this appointment, waiting for that appointment, and taking time off work and all of this. So if we have this, that'll be great in terms of patients' comfort. But anyways, we do liaise with our radiologist in terms of thyroid nodules. So if there is a thyroid nodule, we would like to be given information about the size, the shape, if there's any certain characteristics that I'm going to refer to in next minute. So in this thyroid nodule clinic in the US, they spend only 5 minutes. They do kind of minor procedure if needed, like they fine needle aspiration, only a couple of minutes under local anesthesia, and they take samples if needed. So now we move to risk factors for thyroid nodules. We mentioned the age is a risk factor. So basically, pubertal age is increasing the risk of developing thyroid nodule. Females are having a higher risk than males. If a patient is exposed to ionized radiation, if the patient is having autoimmune thyroiditis, or if the patient is having one of these gene mutations, the PTEN, the MEN, or DICER1, or if there's positive family history of thyroid nodules, or this patient has got iodine deficiency, as you know, that is increasing the size of thyroid gland and as well as making some thyroid nodules. So it's important for, after detecting there is a thyroid nodule and we knew about the risk factors, so it's important that we counsel the patient. And during the counseling, we need to know whether this child was exposed to radiation or not. And if the child is having other symptoms, so there is a possibility here that the child could have a predisposition to thyroid cancer syndromes. So it should be counseled for surveillance, the choice of surveillance, the modality. The modality is a result of shared decision actually between the physician and the patient, whether to go ahead with our surveillance by just neck palpation or neck ultrasound. And there is a debate about that actually. There are pros and cons about it. So what are the advantages of the surveillance in patients with thyroid nodule? What is the advantage if we just do it by palpation? So if we just carried on the surveillance by palpation, so you come to me in the clinic every 4 months, for example, 4 to 6 months, I'll just palpate your neck to feel the gland. I know that's a quick test, okay? It's inexpensive, non-invasive, high specificity, saying the specificity 96 to 100% for detecting thyroid nodule that might represent differentiated thyroid cancer, many true negatives and few false positives for nodules. So that's advantage. The advantage by ultrasound is, again, non-invasive. The sensitivity is higher. Here we were talking about specificity. Sensitivity is high for detecting thyroid nodule that might represent differentiated thyroid cancer, so many true positives and few false negatives for nodules. And again, it's high specificity for detecting thyroid nodule that might represent differentiated thyroid cancer. Detection of thyroid cancer at an early stage compared to neck palpation. So here there is advantage, of course, of the ultrasound on the palpation only, because if there is any kind of small or early stage differentiated thyroid cancer will be detected by ultrasound compared to the palpation. But are there any disadvantages? Yes, there are. So by palpation, there is a low sensitivity. Sensitivity is only sometimes can be 17%. That means few true positives and many false negatives for nodules. Increase in unnecessary invasive procedures due to false positive screening results, and detection of the differentiated thyroid cancer will be at a more advanced stage. So the cancer is very well established there, to the degree that you are able to palpate it now. Therefore, the high risk of morbidity, recurrence, and mortality rate. So it's a bit late in detection of cancers if you just rely on palpation only. Diagnostic value depending on experience of the physician. So someone who is expert in the thyroid field for 20 years is different from someone who is experienced less than 5 years, for example. So it depends on these hand skills of the physician. What are the disadvantages of doing surveillance by ultrasound? Although the sensitivity and specificity to detect thyroid nodules are high, as we mentioned previously, advantages, the diagnostic value of ultrasound for predicting whether a detected nodule is differentiated thyroid cancer is poor. Cannot differentiate whether this is a benign or malignant. So therefore, there is a need to do further kind of investigations. And this can be an indication to do unnecessary invasive procedures due to false positive screening results. However, you could argue this is for best interest of the patient. Yes, I have doubt here, but I'm going to confirm it by doing fine needle aspiration, for example, to rule out malignancy. However, saying that can create some anxiety among the patients and family as well. And remember that we are dealing with kids. So this topic is a bit of argue. Therefore, we need to have certain a strong argument to build up here and to have a guidance on how we should deal with the patients. The argument here, we say the advantage of going ahead with surveillance, both palpation and ultrasound, is to detect the differentiated thyroid cancer at an early stage. And that will reduce the extent of surgery or additional radioiodine therapy, and therefore reducing the morbidity as well as the mortality. If no cancer is found with the surveillance, its intensity or frequency may be reduced in these patients, and that will help decrease the fear of cancer. So that's the advantage of surveillance. What are the disadvantages? Disadvantage of the surveillance is uncertainty of the benefit of early detecting or treatment of differentiated thyroid cancer, since most of the differentiated thyroid cancers can be cured. False positive results leading to unnecessary interventions such as neck ultrasound or even fine needle biopsy. The anxiety, stress, inconvenience for patients may also give higher healthcare cost, especially we're talking about economy these days. So that is a cost, whether the patient is going to pay for it or for the government sector that will cover for all these things. So here are the argument. Detection of small non-aggressive thyroid cancers, which would never have caused clinical problems, and thus may lead to overtreatment. That's another. False negative results of surveillance will lead to inappropriate reassurance of the high-risk patients. Therefore, we need some guidance to move forward. Okay. Perhaps you've heard of the TIRADS. This is the American Clinical Radiology Thyroid Imaging, Thyroid Imaging Reporting and Data System, that's called TIRADS. They give kind of sonographic features, and there are associated points here, grouped according to the what was recommended by the American College of Radiology on composition of the thyroid, on echogenicity, on the shape, on the margin of nodule or the swelling, and the echogenic foci. So for each domain, they have given features as well as scores. And according to the scores, they will classify the patients into TIRADS 1, 2, 3, 4, 5, and so on. So for example, If the echogenicity is, there is no any echoic, so they'll have 0. If it's hyperechoic or isoechoic, then 1. If it's hypoechoic, that 2 is very hypoechoic, that 3. So that means this one is more suspicious. Similarly here for the shape. If the shape is taller than wide, it's suspicious compared if the shape of the nodule is wider than tall. The margin, if it's smooth margin, doesn't sound as suspicious. But if it is irregular or extrathyroidal extension, of course, that will be more suspicious. For echogenic foci, if none or large comet tail artifacts, that's non-suspicious, of course. Macrocalcification is 1, but the peripheral rim calcification gives higher risk or more suspicious. If the punctate echogenic foci, it's even more suspicious. So therefore, according to those features, they classify this TIRADS 1 to 5, and so this is the American clinical radiology, and that I think that came out in perhaps 2016. Then the European came up with another TIRADS based on ultrasound features as well, but this time they have a different kind of domains to look for. So they said if there is no nodule, that's TIRADS 1, that's normal. If it's a pure cyst, so this is how it looks like. If pure cyst or spongiform, so here the cyst and the nodule, so that's TIRADS 2, and that means just benign nodule, and malignancy risk is 0%. But if the nodule is ovoid in shape, smooth isoechoic or hyperechoic, and no features of high suspicion, so that's TIRADS 3, and that is low risk again for malignancy. This is how it looks like. A nodule, ovoid in shape, smooth surface, and the echogenicity is either isoechoic or hyperechoic. So that's a bit of reassurance here because it's low risk. And risk for malignancy is only small, only 2 to 4%. Whereas if the lesion is like this one, is a still smooth surface, but look at the whitish coloration here is higher than here. So it's more echoic here, less echoic here. So if it's hypoechoic, then intermediate risk, TIRADS 4, and that's increasing risk of malignancy to 6 to 17%. And of course, this one is worrying if it's irregular in shape or irregular margin, or if there's microcalcification and marked hypoechogenicity. Look at this. Look at that one. This is hyperechoic. This is significantly hypoechoic. So the hypoechoic is something that we should worry about compared to that one. Then they said, according to the TIRADS, so if you found thyroid nodule, if there is no features of high suspicion, therefore you are dealing with TIRADS 2, 3, or 4, depends on the echogenicity. If you are dealing with TIRADS 2, no need for fine needle aspiration unless there is a compressive effect on other organs. If TIRADS 3, risk, we said only 2 to 4%. TIRADS 3 is low risk. So you do fine needle aspiration only if the size of nodule is more than 2 centimeters. And if it's mildly hypoechoic, we said the hypoechoic we should be a bit worried about. But if it's only mild, that means TIRADS 4, that's only intermediate risk. And you do fine needle aspiration if the size is more than 15 millimeters. Now, if we move to this section, if it's non-oval in shape, if it's rounded in shape or irregular margin or microcalcification or markedly hypoechoic, then that will take us to the high risk of TIRAD 5. Risk of malignancy is high. Therefore, you need to do fine needle aspiration if the size is more than 10. You might do fine needle aspiration if the size is less than 1 centimeter, if the patient is having, active surveillance and the changes happening there as well. Then Jordi Tulai from Italy came to review the effectiveness, let's say, of Thyroid system. And he wrote a very nice article here about the evaluation of the efficacy of the European Thyroids and the American College of Radiology Thyroids and risk stratification of pediatric patients with thyroid nodules. Most of the data has been used for thyroids coming from adult data, not from pediatric data. So what's named Jordi look into the sensitivity and specificity both of the European thyroids and the American College of Radiology thyroids. The sensitivity is there, 73% in the European and 76% in the American College of Radiology. The specificity is slightly higher among the European thyroids. But for those cohort of patients, unnecessary fine needle aspiration or biopsy was about 40% of patients who had, based on this kind of classification, they had unnecessary fine needle biopsy. And 45% of those patients, according to the American classification and American clinical radiology thyroids. So it's a big chunk of patients, they end up having invasive procedures, but tend to be afterwards not necessary. Similarly, on the other side, on the opposite side, missed malignancies, despite all of this kind of classification, 26% or to almost 27% who used European thyroids missed malignancies, and 23%, according to the American College of Radiology thyroids, they missed malignancy. Look at other kind of classification now, adding to them the American Thyroid Association. Again, the missed malignancy is almost 40%. So there is a big need into having more specific guidance for pediatrics rather than adults. We're dealing with pediatrics. Therefore, pediatric endocrinology experts sat with adult endocrinologists, endocrine surgeons, pathologists, oncologists, and nuclear medicine. And they come up with this 2022 European Thyroid Association guidelines for the management of pediatric thyroid nodules and differentiated thyroid cancer. Let me take you through this guidelines step by step. So if we have a suspected thyroid nodule, next step is neck ultrasound. So by now, I think now we have the answer of the first question that we started with. If we have a patient with thyroid nodule, we carried on some blood investigation after clinical evaluation. Next step is neck ultrasound. And preferably to be done by an expert professional. So now ultrasound was done, confirmed nodule. Next step we need to know is the following. These are the features of ultrasound characteristics that we should worry about. The hypoechogenicity, as we mentioned, and we shown the pictures. The calcification, especially if it's a punctate or the microcalcification rather than a macrocalcification. Taller than wide shape of nodule, irregular margins, and increased vascularization. Okay, so now we need to know what is the TSH. If the TSH was suppressed, okay, so it means that we have, it seems to be an active nodule. So we need to check that by nuclear medicine to see how active is that nodule. So perhaps we are dealing with just autonomous nodule, and hemithyroidectomy will be advised for this condition. Calcitonin, it's another biomarker, can be used in patients with suspected and suspicious nodules. If the calcitonin is elevated, if it's very elevated, then those patients are advisable to have total thyroidectomy. If it's mildly elevated, next step is a fine needle biopsy. If the malignancy risk is high, so for example, there is a history of radiation, head and neck radiation, or total body radiation, or there is a predisposition syndromes, or the patient has got macrocephaly. And you remember those gene mutations that we mentioned, the P10, for example. So there is a malignancy risk here. And if the patient has got suspicious nodule with these kind of features that we mentioned, certainly fine needle biopsy is needed. If there is no suspicion, just ultrasound review after 6 to 12 months, and then you reassess going through this circuit. If based on the biopsy results, the pathologist will help you to classify the results into, if it's non-diagnostic, that's Bethesda 1, benign features, Bethesda 2, indifferent, that's 3 and 4, suspicious is 5, and malignant is 6. So if it's suspicious or malignant, the advice is either total thyroidectomy or hemithyroidectomy. If it's indifferent, Bethesda, class 3 or 4, repeat the biopsy in 6 months' time. If it's a benign feature, just ultrasound follow-up after 6 to 12 months for at least 5 years. This is important for follow-up based on the Bethesda finding here. If it's non-diagnostic, then repeat the ultrasound and the biopsy after a minimum of 3 months. And then according to the finding, you just go back into the circuit. Now, question is, what is the evidence, if there is any evidence, regarding molecular testing in fine needle biopsy specimen of thyroid nodule in a child? Would that help to distinguish it from benign nodule? There's no strong evidence to support this. However, David Seminali come up with, and his colleagues come up with this. If you have a thyroid nodule, you did ultrasound, you end up having a fine needle biopsy, and you reach into this indeterminate. You cannot determine what are we dealing with. The cells were not very well differentiated here. So if the patient has got one of these gene mutations, so that means this patient has got low risk molecular profile, and therefore lobectomy and watch and wait approach will be sufficient. However, if the patient has got one of these gene mutations, BRAF or RET or NTRK, then this is a high risk molecular profile, and the patient would be advisable to have total thyroidectomy. Take some images just to refresh our eyes with the ultrasound thyroid. So again, this is thyroid gland. This seems to be the right lobe. You can see here that this is a cystic kind of lesion. This is a solid part of it. And this is a complex thyroid nodule containing part of it cystic, part of it solid. This is how it looks like. This is a complicated thyroid nodule with microcalcification, the white dots. And this is basically very worrisome kind of feature. So this one, we should be very much worried about it. There is an emergent topic for discussion about thyroid nodule ablation, and it's coming more and more these years. There are 3 different of ablations. There is a radiofrequency ablation, ethanol ablation, and laser thermal ablation. Well, ethanol ablation is more towards the cystic kind of nodules, helps better. Mostly use the radiofrequency ablation. Now, before we're moving into the ablations, lobectomy usually performed in patients with compressive symptoms. Say, for example, patient got thyroid nodule that is causing dysphagia or dyspnea. Then a surgery will be indicated to release the pressure. Or sometimes cosmetic concerns, or sometimes according to the patient or parent preference, and should be considered in all apparently benign solid thyroid nodules bigger than 4 centimeters. Now, will the radiofrequency ablation have a role into doing and sorting out these problems without the need to have surgery? Especially, the surgeries carries risk with it. Risk of hypocalcemia because of the hypoparathyroidism that's going to be a result of, or risk of thyroid or risk of vocal cord palsy due to injury to recurrent laryngeal nerve, or the infection or the bleeding, the surgery comes with possible risks. So will the radiofrequency ablation take over? Let's review the literature. This paper from 2021, radiofrequency ablation, a safe and effective treatment for pediatric benign nodular thyroid goiter. So they took number of patients. They took a total of 12 patients. Mean age is 15 years, plus minus 2.8, ranged between 10 to 19 years of age. And all of them, they had benign thyroid nodules. And the longest diameter was 4.1 centimeter plus minus 1.4. Actually, the range of the whole nodules started from 1.5, and the biggest one was 5.9 centimeters. And they had the ablation, 1 to 3 sessions of radio frequency ablation, and the follow-up period extended between 6 to 43 months. The average was 24 months, 2 years, plus minus a year. What they found, this is the interesting finding. The volume of nodule had decreased significantly from 15 mil plus minus 11 to 4 plus minus 4.9 mil with statistical significance. That means the volume reduction rate was 74% plus minus 19.6%. And as I said, the mean number of ablation was 1.4 range. Some patients, they had only 1 session. Some patients had 3 sessions. And one of the patients suffered from transient vocal cord palsy with this radiofrequency ablation, lasted for 53 days spontaneous recovery afterwards. So this paper resulted, that referred into safe kind of methodology of treatment. Look at this goiter. From cosmetic score was 3 and symptoms score was 0. The initial nodule volume was 23.5 mil. At 6 months later, after the ablation, the cosmetic score remained 3 because the swelling remained there. So the cosmetic score actually scored by patients. So swelling remained there. However, you could see the big difference between this size and this size, reduced from 23.5 mil to 15.9 mil after 6 months of treatment. Let's review Grace Kim from US this time. The number of patients was less compared to the previous study. The inclusion criteria for radiofrequency ablation, similar to previous kind of inclusion criteria, under 18, benign cytopathological results on ultrasound guide fine needle aspiration. If there's a pressure or pain symptoms caused by thyroid nodule, dysphagia or obstruction caused by lingual thyroid tissue. So included here patients with lingual thyroid, in addition to just thyroid nodule with benign features. And the follow-up for minimum of 6 months by otolaryngology and endocrine specialist. Look at this patient with lingual thyroid. So with the RFA, that's almost gone. Yeah, you could see that the difference. And they concluded that the RFA is safe and effective option for managing benign thyroid nodules and lingual thyroid glands in pediatric patient population. And this from Helio, the company that supports the radiofrequency ablation. They got this data from collectively from a number of studies and found that after 3 months, there will be a reduction in the volume by 65%. In 6 months, you may see 74.7% of reduction of the volume. And after a year, there's not much difference between 6 months and a year after the ablation. So coming towards the end of this session, take-home messages. Detecting thyroid nodule during clinical examination in children can be the first clue to identifying either genetic condition associated with thyroid cancers, whether syndromic or non-syndromic, so shouldn't be taken simply. For children with history of radiation, particularly at an early age, there is increased risk of thyroid cancer. Therefore, prolonged clinical or ultrasound monitoring of thyroid every 3 to 5 years is essential. Fine needle biopsy should be performed on any nodule larger than 1 centimeter. as the risk of malignancy is higher in children than in adults, particularly for thyroid score 3, 4, and 5. Fine needle biopsy should always be ultrasound guided and, if possible, conducted by practitioner experience in thyroid fine needle biopsy. Due to significantly higher risk of malignancy in Bethesda 3, 4, 5, and 6 cytology in children compared to adults, thyroid surgery is recommended, and the surgical approach should be determined after discussion in specialized thyroid tumor MDT. If I'm going to give you only one message from this talk, a comprehensive clinical assessment is essential for evaluating suspected thyroid nodules in pediatrics. And by this, I would like to thank you very much for your attendance and your participation. I'm happy to take your questions over the next 5 to 10 minutes, and pray for Dr. Sumaya to be much better and to be moderating the session next time. Our next session will be on 28th of December, then 25th of January, and 22nd of February. I'm happy to take your questions.
Thanks, Dr. Hussain, for a elaborated talk on a thyroid nodule and how to approach the thyroid nodule. Why it's important to assess the thyroid nodule? Because the risk of TPC is very common. So we have time for some questions. I have a question from a chat box. Sayyid Daud Khan. Why do females have more thyroid